today I'm going to be talking about reliability of behavior performance, so whether or not behavior performance is variable in people with aphasia, as well as what their brain activation looks like. So we're going to start talking just briefly here about what we're actually looking for when we look for a change in brain activation or change in behavior that's due to therapy. How do we actually look for that or find that? What we do is we measure a baseline measurement. We get a measure of that person's behavior and that person's brain activation, which is associated with a specific task. We can apply some sort of training. In our field, it can be a speech therapy, but many people have looked at other types of training, such as learning how to juggle. And you measure following training what changed about the behavior and what changed about the brain activation. And you ultimately want to be able to correlate whatever's happening with behavior after training with the neural changes that are occurring after training. That's the ultimate goal. And then you can attribute whatever is happening on the brain level and the behavior level to whatever training you applied. Now to do that, you have to have behavior and functional activation that's stable. So the only thing that's going to make it change is that training that you've applied. So that's what we're going to be looking at here, whether or not this neural activation and behavior is actually stable in patients with aphasia. So when we obtain an fMRI signal, what we're looking for is trying to get a measure of activation outside of noise. And a lot of noise happens in the scanner. Some sources of noise come from the scanner itself, but some other sources of noise can come from the patient. So this can include motion, breathing, and task-related activation. If you ask a person perhaps to gesture in the scanner, move their lips in the scanner. All of that creates noise that we ultimately don't want. We just want the signal that's related to the task. And in fMRI, that's a change in blood oxygen level. That's what we measure. So in the raw image there, that's someone who's undergone an fMRI scan. We haven't done anything to this image. This is straight from the scanner. So what we can do is apply some pre-processing methods to it. And these have been refined for the past 25 years. And they allow us to get the best signal-to-noise ratio. We can actually take away as much noise as we can control for, things like motion, and we can get the signal that's just related to the task. And that image there is the same person that you saw on the left, but this time we've applied some of those methods. From that, we can actually apply statistics to investigate whatever we're very interested in looking at. For instance, in this case, this is someone's activation related to a naming task, taking away activation that's related to just looking at abstract pictures. So that's a contrast we've created, and that's activation we know is reliant on the naming ability, and we've also taken out as much noise as possible. So you could just look at individuals, so you can look at how one individual's changed over time, or you can take that out to the group level and actually try and make some general conclusions about whether or not brain activation, what it looks like when they're doing this naming task at a group level. So the reliability that we're going to talk about today is our ability to routinely detect signal from noise at time 1 and time 2, regardless of training. So we need to be able to put someone in the scanner at 2 different time points doing the exact same task and to get the exact same signal profile. And that'll tell us that what we're doing is a reliable method, and that allows us to then move forward and say, if I apply a training, any change I see is going to be a change in neural activation as well. So that's what we're going to be talking about today in terms of fMRI. And we're also going to be talking about behavior. So those two things have to be stable so that when you actually apply a training method, you know whatever changes are resulting comes from the training itself. So one way we can look at whether or not behavior is stable is using a test-retest methodology. And there on the right, you can see a picture just illustrating what you do there. It's a short time window between your first test and your second. And the key is that you're not applying a training. You're looking for any variation in neural activity or behavior that comes just from being tested twice without applying any training. Now, what do we know from healthy adults? We know that behavior is stable from test to retest. Healthy adults are not likely to make erratic decision changes from one time to another. For instance, if we're thinking about a naming task, they're pretty likely to name pictures the same at retest as they did at test. So oftentimes, you won't ever get a testing of behavior stability in healthy adults, because we know for the most part, it will stay the same. But how about activation going on in the brain? We can ask 2 questions to address that. Will the significant voxels and voxels are those that are, it's what we measure brain activity in. It's like a pixel. Will those significant voxels at test still be significant at retest? So is activation at the first time point going to look like activation at the second? And we can also measure whether the magnitude of activity at the first time is the same as the magnitude of activity at the second. So those are two big questions we can ask, and the test-retest methodology lets us do that. So in healthy adults, we know that there's going to be a little bit of brain change happening at retest, and that's okay. We know that's going to happen, and one of the biggest patterns we see is actually at retest, there's a slight decrease in activation. That could be because the person has gotten used to the task, maybe they're more efficient at the task. Anything like that could result in a decrease in activation. But we know that pattern is there, so that doesn't make fMRI data unreliable. Another pattern might be if you have changed your task difficulty halfway through, you might see an increase in brain behavior. Again, we know that might happen, so that's not something we're considering to be unreliable. And from studies of healthy adults, over 100 studies, it's actually one of the most well-researched areas in fMRI. We know that if you scan someone twice without applying any training between, they're very likely to show a similar activation pattern. So that's what we know from healthy adults. But this area is really not well researched in patients with aphasia. So that's what we're going to really focus on today. So the first thing we know is that behavior has to be stable between your test and your retest point in order to attribute any changes to a training that you apply. So what do we know in terms of aphasia? One of the earlier studies was by Fried in 1996. He studied 5 patients with chronic aphasia on a picture naming task. So he was asking the question, if they named a picture incorrectly at the first time, without any training applied, if he gave them the same task, would they again answer incorrectly? That was his question. And the answer was no. There was a great variation between whether or not the persons actually did name it incorrectly again or changed their answer at retest. So this is really highlighting quite a bit of variability in 5 persons with aphasia. Capitani in 2012 also used a picture naming task. Now he only had 2 persons with aphasia that he studied, and they showed an interesting discrepancy, and that the first person was very good at naming at both times. And the second person showed greater accuracy at retest. He got better at naming at retest. And so again, no training was applied there. So that just shows overall a variation in behavior. So those 2 things are giving us an idea that maybe behavior in aphasia is not so stable. A few more studies have been done in this area, still small. Kurland in 2004 looked at 2 persons with aphasia in nonverbal semantic decisions. And now overall accuracy was actually pretty equal on test and retest for both persons, but what did change was reaction time. And reaction time got a lot quicker at retest. And you could argue that that is also a measure of behavior variability, a change in accuracy. And finally, Herbert in 2008, one of the bigger studies here, 10 individuals, looked at picture naming and conversation analysis. I'm just going to report picture naming here. But he found in all people a very strong correlation between picture naming and test and retest. Looks like patients or persons with aphasia might be pretty reliable. But I think the consensus here, at least from these 4 studies, is that behavior performance stability is relatively unclear, and that most of these studies have been pretty small. So we're not really sure whether or not we can say confidently if behavior is going to stay consistent in persons with aphasia at a test-retest type of methodology. How about functional activation? What's going on in the brain? This hasn't been looked at very often, and again, the studies are very small. Eaton in 2008 looked at 4 persons with aphasia, 4 healthy adults, and he was interested in some regions of the brain that were activated during a semantic decision and a verb generation task. So he was interested in specifying regions that had already been shown in other studies, usually in healthy adults. And he wanted to see if his persons with aphasia also activated the same regions as those of the healthy adults. He found that they did. So in general, it looks like persons with aphasia might be as reliable as healthy adults, at least in this study. Zlaflarski in 2011, he used the exact same persons, healthy adults, they're from the same lab actually, but he changed the task. So he looked at picture identification rather than semantic decision, rather than verb generation. And he went at this a little bit differently. So Eaton pre-specified the regions that he was interested in the brain, whereas Zlaflarski did not. He simply mapped the regions most active in persons with aphasia during picture identification versus those with healthy adults. And as expected, they're going to be very different, most likely due to large lesions that we're seeing in persons with aphasia. Therefore, they're having to use some other areas to complete the picture identification task. But what's more interesting about this study is that within the group, so within the 4 persons with aphasia, the activation from test to retest was pretty similar. They seem to activate to the same extent at test and at retest. And that is stronger evidence that perhaps this is a reliable functional activation. Again, these are quite small studies. Not a lot to take away from this, but they do err on the side of being relatively reliable. There on the right, it's a little hard to see, but they've mapped out a measure of reliability that I will actually talk about in a few slides. Any area in red is an area that was reliably activated at test and again at retest. And any area at blue was also reliably activated, but to a much less extent. So 0.4, not as good, 0.7, excellent. And that's mapped on one individual's brain now. So there's really no consensus, and all of the studies have been quite small on whether performance is reliable, if that baseline is stable in patients with aphasia, and whether neural activation is stable. So large studies really need to be done in this area, which is what we're doing right now in the lab. And we're asking 2 main questions. How is behavior performance on a picture naming task at test and retest? And what's the cortical activation produced during this task at test and retest? Those are the 2 big questions we're looking at. We have 60 individuals. So this is a huge number in terms of studies that have previously been done in this area. And we're looking at individuals who've been diagnosed as having aphasia on the Western Aphasia Battery Aphasia Quotient. That's what WAB-AQ stands for. And if they score under 93.8, they are considered to have aphasia. And you can see our study mean here is 58.87. We've got different types as well. So these are the types of aphasia that are on the right, ranging from the largest group, which is Broca's aphasia, the second largest, which is anomia, distinct problem in naming. And then you've got other, which includes conduction and transcortical, as well as global, and Wernicke's. So Wernicke's here is our smallest group. If you look to the left, that is our lesion overlap map of the 60 individuals included in this study. You can see there on the Sylvian fissure, it's very red, which indicates that's the area that most people have a lesion in, and specifically it's around 36 people share that area of lesion. As you get darker, less people share the area of lesion. So we're specifically interested in picture naming, and this is what our in-scanner task looks like. Has 60 different stimuli, 40 of which are object pictures, which you can see 2 examples of, bucket and mouse, and 20 are abstract pictures, which you can see an example there at the bottom. Now the persons are instructed to name out loud the object picture, bucket, and be silent for the abstract pictures. And they're presented with a new picture every 10 seconds. What we do is we record their audio while they're in the scanner, and it's scored offline by a speech therapist. And they're scored relatively detailed, so it can be a correct response, it can be a no response, or it can be a type of error. And those errors range from semantic, phonological, self-correction. I think there's about 7 different types of errors that we rate them on. Within the scanner, we use a sparse design, which is a type of block design, and it just measures a single point after a picture has been presented. Now there's a good reason for this. The picture is presented, and the person says out loud what they think the answer is, which gives a lot of motion, a lot of noise. And so we take the scan immediately after they're finished speaking. And so that's where you can see here that green line is when we've scanned. And the bold response is what we're actually measuring in terms of the functional activation in the brain. I mentioned earlier blood oxygen level, that's what that is. And we use a SPM, which is statistical parametric mapping, pre-processing pipeline. It's very popular to use, but it does have some in-house customization from our team here at USC. Now, what's really important is that in test and retest, the interval is small. If you're measuring people 3 months apart, something may have happened in their life that is causing a change to behavior, and you're really not able to measure whether or not that behavior is stable. So what we tried to do is keep it within a 1 to 3 day window that they were tested and then retested. So it is a very small time interval. And our reliability measures, we have a few questions we want to answer. Will the response at test be the exact same at retest? If they got the naming right at test, will it still be right at retest? And we can measure that using the intra-class correlation coefficient. The ICC is what you'll see me refer to it as throughout the slideshow. And this is arguably the most common measurement of reliability. In this case, because we're looking within a person, it's very similar to a Pearson R correlation. You can think of it in that way as well. I just want to point out, a person can be reliably good. They can get all correct answers at test and retest. They can also be reliably poor. They can get all semantic errors at test and at retest. So reliability is not a measurement of success, per se. So that's one thing to keep in mind. So what we need to do then is actually see if anything at a lower level changes. Is there a change in accuracy from test to retest, in number of correct responses, in no responses, and in errors? So we need to look at that as well, because reliability is not telling that story. In terms of what's going on in the brain, we can also ask 2 questions. And I spoke about this earlier, but we want to see if the activation at test looks like the activation at retest. And we can do this by using something called the DICE coefficient. I'll generally refer to it as the DICE throughout here. It has very similar measurements to the ICC that you see right there. So 0.75 is excellent. We can also ask whether the magnitude, the amount of brain activity, is similar between test and retest. Are they activating to the same amount on this naming task? And we can look at that with an ICC as well. So this is what we're going to go through now, and we'll begin with just answering some of those behavior performance questions. Will the response at test be the same as at retest? Probably not. So we've got an average reliability measurement of 0.32. If you recall, anything under 0.4 is generally considered poor. So within this group, we're seeing a lot of variation. If you look at the histogram on the right, you're seeing some people with a verging on moderate ICC, they're in the 0.45 rounded group. But you're also seeing a large amount of people there in the 0.15, so a lot of really unreliable people. And again, this is not a measurement of success on the task. It's just whether or not they change their answer from time 1 to time 2. And it looks like, as a group, they do change their answers quite often. This maybe is not as understandable just to look at the histogram. So I wanted to point out 3 people. These are their actual scores. On the left, you can see the picture they were trying to name, the picture that was presented to them. Now this first person, P1, you can look down their test column. They had a lot of no responses, a few errors, perseveration, an unrelated error. And at their retest, there are no matches with the exception of 1 correct there. So they changed their answer a lot. If you look in the middle, that's someone who is reliable but poor at the task. So they have a lot of semantic errors which replicate from time 1 and time 2. And if you look in the right, it's someone who's reliable and very good. So they almost got every single answer correct at time 1 and time 2. So that's just to illustrate reliability. It's not really telling the full story, but it is telling us about whether or not they are, unstable in their choices that they make. And it does appear they are. So we can ask the next question as to whether this instability of behavior has anything to do with how severe they are in terms of their aphasia. And we do find a significant positive correlation, but from this, if you looked at it briefly, you might deduce that someone who is less severe, so someone who has a higher WOP score, they're in the y-axis, may be more likely to be reliable. But I want to hesitate in making that conclusion, because if you cut off some of the people who have a lower WOP score, what you're seeing is a pretty variable pattern. I think you would all agree it looks like there's no real pattern if you just place that square over the top. And so you might be able to say with a little bit of certainty that perhaps more mild people are indeed more reliable, but take it with a grain of salt, because it does look like the group is pretty variable as a whole. Now, reliability didn't tell us anything about whether a specific type of performance changed. And for us who work in aphasia therapy, we want a therapy to give more correct responses after therapy. That's the goal. So we need to establish that they're not going to randomly get more correct responses if retested. So that's really what we need to look at. And actually they do. So with no training applied, just being tested twice, these 60 individuals as a group do make more responses, correct responses at retest. So this is really a warning sign that we need to consider some behavior instability here, and that they may just get better over time. And that's something to take into consideration when we think about the effect of therapy. Another trend we see is that there are fewer no responses at retest. People are more likely to give it a go at retest than they are at test. Now, the thing to remember is that accuracy takes into account both of these things, both correct and no responses. And here, we're actually not seeing a significant change in accuracy, and that's because of the trend that's going on. Fewer no responses, greater correct is really evening out the accuracy calculation. So if I were to just look at accuracy for this group, I wouldn't have seen a change. So that's also an indication of being a bit more specific with what we're looking at in terms of behavior. We can ask a very similar question in terms of, would a mild person be more likely to be the one improving their naming at retest? That might be the intuition that's going on. And that is most definitely not the case. There's no correlation between the severity of the person's aphasia and whether or not they're making more correct answers at retest. That's really interesting, I think. And it also illustrates a lot of variability. So there in the box, those are all individuals who have made improvements in their naming at retest, and you can see along the bottom the WAB-AQ. So it's all across the board in terms of severity. Okay, so what do we know? We know that persons with aphasia are likely to change their response from test to retest, no training applied. Okay, we know there's a small relationship with whether or not they are more severe in their diagnosis, but overall, the group is pretty variable. We know that there's improved picture naming at retest without training, but there's no relationship with their severity of diagnosis and that improvement. So a person that's severe and a person that's mild are just as likely to make an improvement. At retest, no training applied. So to me, that seems pretty variable. There's a lot of behavioral variation going on in this group of 60. What's going on in the brain? So we can ask, is the activation you saw at test looking like the activation you see at retest? And that's where we can use the DICE coefficient here. So again, just to remind you, a DICE of 0.4 or below is pretty poor. And here I'm showing you an average of 0.32. And what that is telling us is that if I were to take an image of the group at test and an image of the group at retest and overlay them, they look very different. That's what that's telling us. Now recall the trend that we see in healthy adults, that almost always at retest or time 2, activation goes down. Might be due to task exposure, they might be getting better at the task. So we wanted to see if we actually saw that in our group of individuals as well. And we do. Not a very stringent threshold, I have to say. This is the SPM default threshold. And it doesn't survive if we do become a bit more stringent. And so what that means is, if we're just looking, basically if activation does decrease to retest, it does. But if we want to really increase our confidence in that, they kind of look equal. And we can also ask, which goes along with this first question, whether or not the areas that are active at test are still the areas activated at retest. And we find that there's a little bit of difference. There's actually some new areas that are showing up at retest that we didn't see at test. I would argue these aren't new. SPM would say anything within an 8 millimeter peak of activation, so height of activation is a new area. But if you look here, these areas are very, very well connected. Blue is retest activation, red is test activation, and purple is overlap. And so the blue, or the new activation, really is kind of an extension of the old activation. It's not a new area. So I would argue that it's perhaps a recruitment of areas involved in this test that's occurring at retest. It's occurring at time 2. So we can also step back and ask a different question. Is the level of activation, the amount of activation, similar between test and retest? And we can do this by looking at regions of interest. So in aphasia therapy research, we often approach the question of whether or not therapy is affecting brain response by looking at specific regions that are active during the task that they're doing. In our case, what's active during naming? And we specified that here. I've listed some of the areas and some of the MNI coordinates, which means where they're located in the brain. So that's the template that we use to kind of compare activation across groups. And you can see on the bottom brains here, brain slices in red are the regions of interest that we're specifically interested in. And we want to see within those regions, what's the activation looking like at test and at retest? Are they the same? Are they the same magnitude? And that's what we can ask with this. We can use our friend the ICC once again. And we can say, I'm not interested in whether or not activation reaches a certain height. I'm not going to threshold it. So this is unthresholded activation. I'm just interested as to whether or not there is activation in these regions of interest, and whether or not that activation is stable, whether it is the same at time 2. And it looks pretty good, actually. So our average is 0.53. That falls in the good range. So it does mean that in these regions of interest, they're just as likely to produce some activation at retest as they did at test. Pretty good. What happens if I say I'm only interested in activation that reaches a certain amount? This is called thresholding, and it's something we do in neuroscience quite a lot. We're being more stringent, saying I'm only interested in a specific level of activation. What does that look like in terms of the change from test to retest? A little bit less reliable. We're at 0.38, so we're right on the cusp of being considered moderate. And it's just saying that perhaps because we applied a more stringent threshold and activation in general goes down at that retest, that we're just not catching as many voxels or as much activation in retest, which is why the reliability might be a little bit down compared to up-thresholded. Let's just summarize. What we've shown in terms of looking at the whole brain is relatively reliable activation there on the left if we're not interested in a certain level of activation, so unthresholded. We're also showing if we are interested in a certain level of activation, it's pretty reliable. It's on the cusp of being moderately reliable, and that's due to several reasons I just mentioned. And if you look here at the gray bars, those are the retest, you can see that almost every gray bar is smaller than the orange bars, which means there is a kind of general decrease going on in terms of the amount of activation at retest. And this is the pattern I talked about, that it always occurs in healthy adults. So we're just saying that here in our group of 60 persons with aphasia as well. There's one instance where it doesn't go down, and that's in the right lower end of the curriculum. And we might look a bit more into that. Okay, so I'd like to summarize and bring this talk to a conclusion with some other future insights for research. So what we've shown in this large group of persons with aphasia is that they are actually very likely to improve their picture naming at test and retest. So they haven't applied any training, but they're going to improve their naming. So it's not a training effect. They're also very likely to change their answer from a test to retest. So they're variable. They're more likely to change. This is not what we see in healthy adults. There is a small trend that a person with more mild aphasia may be more reliable, but it's a pretty weak trend. And in general, can't really classify if someone's going to be reliable or not. It looks pretty variable as a group. And if we look a little bit deeper into the relationship of whether or not someone will improve their naming at retest and whether or not they are more mild in their aphasia, we actually don't see that much of a relationship. So someone who's severe and someone who's mild have just as likely of a chance to improve their naming at retest. And what do we see in terms of functional activation? If they activated their activation profile, what their brain looked like at test during this naming task, a little bit different in terms of what they would activate at retest. So there's not perfect overlap of test and retest in terms of activation. That might not be a worry, because as I said, we do focus on regions of interest in terms of aphasia therapy research many times. So perhaps that's not the biggest worry. What we do see, though, is that there's some extensions of activation going on at retest, maybe some recruitment of surrounding areas that were activated at test and now are a little bit more activated at retest, spatially bigger. If we look within regions of interest, so for us it's within regions that are active during the naming test, we can see that if you threshold it, if you apply a constraint to how high you want your activation to be, reliability does go down, at least in the regions that we showed. But if you don't statistically cap what you're looking at in terms of brain activation, it's pretty good reliability. And this is what's been shown in the 2 studies I highlighted earlier. Pretty good reliability in regions of interest. And this is the last thing I mentioned on the previous slide, which is, like in healthy adults, we see that pattern of a decrease in activation and retest, which could be due to exposure, task getting easier, perhaps. Unclear what it is, but we also see that here in our 60 individuals as in healthy adults. So this is our summary. I think we've made this clear throughout our presentation today. And what I'd like to do next is just talk a little bit about how this implicates future research in this area. And I think it does have big implications for therapy research especially. So fMRI studies longitudinally, so many time points, are especially important for understanding therapy effectiveness, both in behavior as well as what's going on in the brain. They're very important. They've been used for the last 25, 30 years. But now what we understand is that behavior is pretty variable in this population. And what we can't assume is that behavior post-therapy is just due to therapy. There's some variability occurring. So now that we know that, we have to make some precautions. We have to make sure that research does include this variability. And one way, of course, is to correlate any changes, any behavior changes after therapy with any neural changes after therapy. And this is something that's very routine to do in studies. But now, on top of that, we need to somehow add in that variability as a factor. So we need to be able to take out whatever is due to the patient's inherent variability so that what's left is just due to training or just due to therapy. That's what we need to be able to do. So if we measure people's variability, I've just given you an example there at the bottom, you can measure it before therapy and after. If you use that understanding of variability, the person's natural response, you can get a better idea of what change is actually due to just therapy. And you can approach that from the neuroscience level as well as the behavior level. And finally, some recent evidence has come out that says maybe even variability might predict therapy outcome. This is very new evidence, and it's saying if a person is more variable, actually, they may show a better treatment effect. And it is very preliminary in a smaller study than our 60 here, but it is, again, hammering home this idea of variability occurs in patients with aphasia. Whatever change we see after therapy may not just be due to therapy, but that also variability may help us predict and get better prognosis as well, which currently there's not a lot of tools for prognosis in this area of research. So those are the research implications that I'd like to put forward that are, I hope, the research world kind of turns to in the future. And I want to say a big thank you to 2 labs. So the fMRIs were done here at USC as well as at the Medical University of South Carolina, and just some pictures of individuals in our lab. Thanks so much.
Questions or comments from the
Oops, sorry.
If you get questions from the room, can you repeat them?
Oh, sure. Yeah.
Do you have online questions, or should we start with questions?
Not yet.
Not yet, so go ahead.
So we'll open questions to the room first.
So you can see them right from the chat box.
Yeah, then we'll
Right.
open to online.
Excellent.
Yes.
So 2 questions jump out at me. The first one is, obviously there's a lot of variability in test-retest reliability across subjects. what do you think determines this? It doesn't seem to be overall aphasia severity. So perhaps something else like just general cognitive reserve, something like that?
I think it could be quite a few things. There's been some research done in attention and arousal variability in aphasia. I believe Alex brought that up yesterday in 1991. Sorry, the question was what other factors could contribute to this variability in language other than language. And I think attention or cognitive resources are absolutely something to be considered. I think we can look at type as well, type of aphasia, so whether it's a fluent or a non-fluent, if there's more variability in one type of aphasia than another, but my inkling is that it actually does have a lot to do with cognition, and I'd really like to look into that.
So what about this test-retest reliability? Do you think this relates to then performance in aphasia therapy across days? So that somebody who is not consistent from day one and day two in testing, would you expect the same thing in treatment?
That's a great question. We have speech therapists in the audience. So he asked whether or not this variability might also be shown in speech therapy performance, as well as in testing performance. I've done a little bit, I've sat in on a lot of speech therapy sessions, and my clinical intuition is that yes, but I think also there's a little bit of help going on from the speech therapist in the room that is driving more of a forward motion, so more reliability because of the person kind of leading the aphasia therapy. I don't know if I said that well. Whereas in a naming task like this, they're not giving reinforcement of any kind. And I think that's really difficult, not having reinforcement and having to go through a battery of 40 naming tests in a scanner. So I think the biggest factor there is that they may be less variable face-to-face speech therapy because there is that reinforcement and there is that consistency. Yeah.
In one of your slides, you showed multiple baselines. You only showed two. I was just wondering how deliberate that was, because if you want to do something like just calculated effect size, for example, which is very common in normal behavioral studies, you need at minimum 3, right? Is that something that you think is feasible to do for imaging analysis, to have multiple baselines and calculate perhaps per voxel a threshold that would need to be exceeded for something to count as being different from baseline?
I think that's the goal, but I think in terms of cost, probably not. I think it's quite costly to do more. Even I think people stray away from doing even more than 2 just because of the cost. That was brought up in a 2013 paper by Sweta Kieran in Boston. She mentioned that a lot of people stray away from that because of the cost. And I also want to highlight that it's really difficult to get triple baselines of behavior because the amount of time that speech therapists spend in administering these tasks and getting people to come to where the tasks are being administered is pretty big. But I agree, we do need to come up with a way that is going to quantify this variability to the best of our ability in order to put it back into these analyses to figure out what's just due to therapy. I'll be honest, I don't know what that is, but I've done a little bit of reading, and it seems like within at least the psychology research and development, there's some ideas about how to do this. So I'd like to look into that. But currently, I do think a triple baseline would be pretty difficult to actually do. Yeah.
So to sort of elaborate on this question, it seems like it's a great idea to have several baseline sessions as well as several post-treatment sessions for behavior, because as you showed, behavior is so variable. But since fMRI is supposedly a lot more stable, maybe it makes sense to just have one fMRI session pre-treatment and another one post-treatment.
That could definitely.
What do you think about that?
Oh, sorry. A colleague in the room asked whether or not, since fMRI looks to be pretty reliable but behavior is not, whether we can just do one time point of fMRI but many time points of behavior. From what I've looked at least in these 60, it does seem like there's some reliability in fMRI, but I'm hesitant to say that it's super reliable. I still think a double baseline would be prudent. That's a really difficult question. I would hesitate to say just use one.
So I understand these results are from tests using exactly the same stimulus in
Yeah.
pre and post test. Has there been any studies that look at changing the materials, one version of a test and another version of a test, which will avoid the kind of root repetition effects?
I think so the question was whether or not, because in this study, the stimuli on test and retest, so the naming battery that we use was the exact same, and whether or not there have been any studies that use different stimuli for test and retest. I think the good thing is in test and retest, you kind of want to see the response on the same test twice, but it would be really interesting to see whether maybe even doing 3, where you do on test you do the first set of stimuli, retest you do another, and then on the third you do back that test, just to see whether there was a change in that as well. As far as I know, I don't know if any of you have changed the stimuli. I think the overall idea of test retest is to hold everything constant and just see if within individual, if anything changes.
But I mean, really the goal of therapy is not to improve performance on that picture, it's to improve ability to come up with names, So, yes, another way to do it, again, there might be issues with properly non-stimuli and baseline and this kind of issues, but using a different set of stimulus might also be a way to kind of avoid some of the effects here. You can't use exact, you can't tell if the response is the same or different because the stimuli are different. But nonetheless, if you can improve accuracy from 50% to 70% on a different set of pictures,
No, that's very true. I just remembered Herbert in 2008 looked at conversation analysis, and it's what we do here describing, I think it was the cookie theft picture, and they looked at whether or not the number of words, some other grammatical analyses, whether those changed from time 1 to time 2. And I guess that is a bit more ecologically valid than just giving them 2-word lists. And they are more liable to maybe consider the picture differently at retest. And he found that about half the measures were reliable and the other half changed. So that's the only one I can think of that might have done something similar to what you're thinking. I agree though, I think ecologically valid is really the way forward to look, because that is what therapy is trying to do. Oh, I haven't looked online, so.
Doesn't look good. So people online, final opportunity to ask a question. You can also do that in the chat box if you feel that we're not hearing you.
Someone said thank you.
I have one question.
Oh, yeah.
Is it possible in order to get retest reliability fairly quickly with data that many labs might already have, is to just separate something like the P&T into 3 separate sections? Or something,
Probably.
4 separate sections?
Absolutely. What's something that's almost always done with a baseline? I know P&T here is done. At Cambridge we did the CAT. We use the CAT? Comprehensive Aphasia test, and that has some instances that are kind of like the P&T in them. So maybe in the UK something like the CAT could be shared between. Is there anything else similar to the P&T that we use here? Boston naming test that you use very often?
That's just something that we do already for every
Yeah.
patient anyways.
No, that's
So,
a good idea. Open up the lab sharing and maybe get this to be even bigger, really find out the variability. We can look at this in our P&Ts too. We have a lot. Another good question.
Question on that? Thank you very much.
Thanks, guys.
We're stopping the recording. Thanks everybody for tuning in, and hope to see you in 2 weeks' time.